Next up, we have Dr. Stephen Bernard. Dr. Bernard is a plastic surgeon here at the Cleveland Clinic and a specialist in microsurgery and breast reconstruction. He is an associate professor and the prior head of the residency program here. He has authored over 50 peer-reviewed articles, many of which are on breast reconstruction. Thank you.
All right, good morning. I'm not sure I've ever been to a meeting where we're actually a little ahead of time. So I'm going to talk really slow because usually I talk really very fast. So, all right, so this is a little bit out of place because it's not specifically about lobular carcinoma and it's a little bit broader. And I even made the title of the talk a little bit broader because originally it said implant. And I am going to bring it back to implant. And I'm also going to bring it back to specifically to lobular a little bit. So hang in there with me. So as it suggests in the title, this is an update. And when Dr. Valente asked me to do this, I thought, yeah, that's great. I did this a few years ago. It'll take me about 10 minutes. Not much has changed. Well, in reality, I actually did it over 10 years ago, and an unbelievable amount has changed since I saw it. So what is it that's changed? Let's first start and kind of go, I'll just put this slide up because this is what's going through a plastic surgeon's mind when we first see a patient. We get a referral from the breast surgeon. We look to see, are they a good candidate in general to have this reconstruction? And then we look to how hard is that reconstruction going to be? And the patient you're looking at is a fairly average patient. We take into account tumor size, where the tumor is, the age of the patient, and some of the other factors such as chemotherapy and adjuvant, et cetera. And the dilemmas back then in 2010, these come from my 10-year-old slides, are that we really had no idea whether someone was going to get postoperative radiation, but largely most patients really didn't. We did know that radiation therapy affected all types of reconstructions negatively in some way. And we also know that reconstruction affected radiation therapy negatively. And so I'm going to talk about each of those a little bit more. And then we also know that, with that thrown into it, radiation therapy, it made planning for that surgery a lot more difficult. So this is the algorithm that I put up 10 years ago. If there's a known need for radiation therapy, it was a minority of patients. We did a skin-sparing mastectomy. We put a tissue expander in with the idea that somewhere down the line we would use the patient's own tissue. That usually meant their abdomen for a DIEP. If it was unknown, just kind of coming into play at that point was doing a sentinel node biopsy and then making a decision based on that. Sometimes that was done intraoperatively. In other words, the sentinel node biopsy was done. And then if it was positive, we would change our plan right mid-stage there. If we were going to do autologous, even if we were going to do it deep, we put a tissue expander in, closed up, and that was kind of the end of the case. Another way we did it was, and this still goes on, but to a much lesser degree for many reasons that I'll outline in a little bit, is to do that sentinel lymph node biopsy ahead of time so you know whether there's a need for axillary dissection and you know whether there's a need for, ultimately for radiation therapy. If we thought that radiation therapy chances were low, we just went ahead with what our plan was, and that was that. It really didn't influence the plan. This is kind of summarizing that slide again. This is the conclusion slide I had back then. So what hasn't changed? So 10 years on, all of this has changed a bit incrementally, but there are still some of these effects that affect everything we do as plastic surgeons and also as breast surgeons. We do know that the aesthetics are altered somehow. Things have changed with radiation therapy, but we know that radiation therapy causes fibrosis and contracture, and it affects different tissues differently, and that's one of the advances we sort of have. It causes telangiectasia of the skin. Some of these changes get a little bit worse with each year. And you see what one paper from 2010 considered as a very good result at about 30%, a good result, fair, and then poor regarding, and these are patients that underwent lumpectomy and then radiation therapy. Other effects, it increases the risk for lymphedema. fibrosis not just of the breast, but also surrounding tissues, heart, lung, and from our standpoint, shoulder, because that did affect how we did our reconstructions. And it also was associated with an increase in pain. So what are the effects of radiation, of reconstruction on radiation therapy? I just kind of told you that we even have some negative effects, and so that is now impacting how well the patient is treated. So, we want to minimize anything that's going to decrease the effectiveness of radiation therapy. It depends on what autologous tissue we're using, but it can be denser than breast tissue, so that affects how the planning goes. There's the increase in damage due to the having to really alter the radiation plan to accommodate the reconstruction, so that now these angles that you could otherwise avoid tissues such as the heart and the lung are now affected. And it's sort of increased the multiple beam effect. So the planning for the radiation therapist has become quite a bit more difficult, but by the same token, they've also gotten quite a bit better with it. It also makes it a little bit more difficult to treat internal mammary nodes. And so I have there that radiation therapy, it really kind of depends on which type we do, autologous, implant, or a combination thereof. On the other end of the spectrum, this is what radiation therapy still does for the breast. So this is a little bit more extreme, and we frankly don't know with each patient how much radiation therapy is going to affect them. Here's a patient who underwent an autologous reconstruction, so she had a DEEP, and then she underwent radiation therapy. And for the most part, I actually don't have patients come back during the radiation therapy because this scares me. They generally look like this, but then 3 months later, they look pretty good, and I'm going to show some of that as well. 20% of patients needed a salvage procedure of some type because of this, and the rate for those procedures increased every year in the 5-year study that these patients are based on. This is one of my patients. Pain was associated with 30% of patients versus 1% of those patients that didn't have contracture due to that. Those effects don't end. There's sort of a lifetime issue or issues that potentially happen. This is a patient that had, this is old. This is a slide, I think, from the aughts that, is that how we're saying it now, the aughts? It's a long time ago. But this is a patient who underwent radiation therapy after an implant reconstruction, and you take an insensate breast. Patient really doesn't know if there's pressure on it in any way, so they really don't know that they're creating skin damage. It's over this irradiated tissue. It just doesn't spontaneously heal, and the result is what you're seeing up here. So this is exposed implant, and this is years out. This is 5 years out for this patient. And down here is, this is another implant patient, and I'm going to show you how we have gotten better. Again, this is an older slide. There's also rare secondary tumors such as angiosarcomas. We tend to see these certainly more frequently than perhaps community hospitals, but they're real. And that poor wound healing effect affects how we can sort of do revisions, change implants out, et cetera. This is our own work, and when we look at what influences quality of life for patients after breast reconstruction, the things that negatively affect it are listed below, and the big ones really are complications and higher BMIs. More revisions probably falls under complications. The amount of time that's elapsed since the reconstruction, which suggests that some of these reconstructions aren't holding up as well, and then finally radiation therapy. And realize that this paper was published in 2020, so this is really data based on some of those things I showed you in the first 10 slides or so. So what has changed? So things really have pretty radically changed. Patients are getting more radiation therapy. The radiation therapy has improved dramatically, but from my standpoint, our implant-based reconstructions have vastly improved. The autologous reconstructions haven't changed much, so I'll touch on it a bit, but basically it's the implant reconstructions that have improved radically. Radiation therapy is no longer a moving target. If you looked in 2010, I'm sure everyone in this room, at least closer to my age, remembers that basically if you had anything less than 4 lymph nodes, you pretty much didn't get radiation therapy. And if you kind of think of all of your patients, that meant that most patients really did not get radiation therapy. So that was really the kind of the law, but right around 2010, studies from the Danish studies came out that showed that really they needed to increase the patients that they were doing radiation therapy for, because there was actually a survival benefit, not just a disease-free benefit, but a survival benefit. So, so it made sense to increase it. So now anyone with a positive, well, there's exceptions to everything, but basically if you have a positive lymph node, there's going to be a recommendation for radiation therapy. And everything else I've listed here, inflammatory, medial, age less than 45 is going to lean towards radiation therapy. ER negatives, tumors more than 4 centimeters. These are all reasons that radiation therapy is more prevalent. But the radiation treatments have improved, and I will say I do see a pretty significant difference between the patients that come out of our own hospitals than perhaps some of the outlying hospitals that come into us. So it is very important to kind of keep up on the latest things. I showed this slide earlier, and I'm going to bring this up one more time, and there's a reason for it. If you look here, the irradiated breast is the patient's right breast, and I will say this is something that you really have to ask the patient, because as the plastic surgeon, our assumption is that, or my assumption certainly was 10 years ago, that radiation therapy is going to create damage. The patient often prefers that irradiated breast, and I have a good example of that later, as I said. So what have we done in reconstruction that's improved? Basically, we've really ramped up doing oncoplastic reductions, and which all require, or most require, radiation therapy. And nipple-sparing mastectomy was, when I first started here at the clinic, rare and has become more common. We've changed to prepectoral. I'll describe in a minute why that's important, and going direct to implant. Starting with oncoplastic reduction, and you just heard that perhaps oncoplastic reduction or lumpectomy isn't quite as applicable under patients with lobular carcinoma. But in those patients where it is, this really affords, and the paper that was just shown really shows that it affords our ability to take more tissue out. So when I collaborate with Dr. Valente, we go up to the patient together, we look at where the tumor is, and I really decide on how I'm doing it. There's a pretty good paper out in our literature that shows about 10 different ways to do oncoplastic reduction. But really, in my opinion, you can pretty much boil it down to what you're seeing here, either a superior pedicle or an inferior pedicle. And I'm happy to go into more detail, for anyone that's curious about this. But almost every type of resection can be designed around these two operations. You have to have some knowledge of how to do them well, but basically you can get the tissue out you need, plus a lot more tissue, and actually have the breast looking better when it's all said and done. Here's an example. Generally, we will do this as one operation, sometimes by patient preference or treatment expediency. We will do one side at a time. So that's what we did, but it gives you a good idea of how we do it. So you see someone with very large ptotic breasts, really a perfect candidate for a reduction if she didn't have cancer, but she did. So she had the oncoplastic reduction on the right side. She underwent radiation therapy, and then about 3 months after that radiation therapy, we did a reduction on the opposite side. The next thing I want to talk about is nipple-sparing mastectomy, because this is really a game changer from the standpoint of radiation therapy and reconstruction. So it was really Dr. Crow back in 2004 who popularized this here at the Cleveland Clinic. And so prior to that, nipple-sparing mastectomies were done. They were really done for at-risk patients, usually as prophylactic. It all changed with the study that Dr. Crow did back then, and at this point, there really is no turning back. It's a better treatment, certainly from the reconstructive surgeon standpoint, and the indications are increasing. And how we do it is increasing. So we can probably do some form of nipple sparing in approximately half of the patients that we see. certainly genetic testing has made a big difference in this, and we're doing this for a lot of prophylactics. We've figured out ways to even do it with ptosis, because our general rule is if you have to move the nipple, we couldn't save the nipple, but we've figured out ways that we can get around that, and including staging reconstructions for these prophylactic and using things like something called an omega flap. And so you see two people with about the same shape of breast here, so that, you know, this is one that was done where the nipple was removed. And this is pretty common for the aesthetics that we could get back then. And then you see this patient. This was done at the beginning of COVID. It was always meant to be a bilateral, but she had cancer. Beginning of COVID, we just, Dr. Valente and I did this patient. We just did the right side and then came back to do the left side better. And she lets me show this to other patients. Perfect patient because they see before and after. But this, nothing other than the mastectomy and a direct implant reconstruction was done on that right side. It is, from an aesthetic standpoint, worlds better than a skin-sparing mastectomy. The indications are pretty limited, and the results, this is what I really considered a home run back in, prior to 2010. So why does it work, and how is it better for radiation therapy? Well, one of the things that I think just about every reconstructive surgeon uses is some form of ADM. I use alloderm, but there are other types of ADM out here that can do similar kinds of things. But by saving the nipple, it's hard to appreciate some of these things, but you maintain breast projection. Anytime you take skin out of the central part of the breast, you're flattening the breast, and you're ruining the aesthetics of the breast. And then patients like their nipples. They will do just about anything to save their nipples. So, even if it means changing the operation radically. Next, I want to talk about prepectoral, and getting back to that, I'm going to go back for a second. Getting back to ADM, so this added thickness to, to the sort of, if you look at sort of the outside world and covering that implant, it depends on the patient, but the tissue and the subcutaneous tissue can be very thin over after a mastectomy just to get the breast out. This adds a little bit of thickness, it adds a little bit of protection to the implant, and the radiation therapy really doesn't affect this. So overall, the breast aesthetics are better and it's better tolerated. And there are a few papers out showing that as well. Prepectoral position. So this is the next thing that is a big change over about the last 5 years. So we now, in general, we will probably 9 times or more out of 10, I will put the implant on top of the muscle. And you might say, well, why does that help with radiation therapy? Radiation affects tissues differently. So even though it causes a contracture both in the skin and the muscle, it doesn't matter so much in the skin, but it really does matter in the muscle. So when that muscle doesn't have its full excursion, you're putting it out of place by sticking it on top of an implant. It's no longer in the plane that it's supposed to be in. It really changes pretty radically. And if you'll think back a couple slides ago, that's what you end up with. You end up with an implant that's sort of sitting on someone's clavicle, and it's worsened by radiation therapy. And looking at the patients, we're able to position the implant better, and there's decreased pain. This is just kind of looking at how we do the incisions, because this has been an improvement as well. We still have to use sort of A, B, and C occasionally, and mostly that's depending on how close that tumor is to the skin. So again, a collaboration between the plastic surgeon and the breast surgeon. But what we've kind of ended up with is this inframammary fold for a couple of reasons. And some of it's lucky, and some of it is, just works out better. But basically, this is aesthetically the best. That's the lucky, because we would always choose, of course, treatment prior to aesthetics. But aesthetically, this is the best place. It's hidden. You don't see these incisions. You can make an incision halfway around the breast, and most of the time, you're not even going to see it in these patients. And I'll show you in a couple in just a minute here. Any incision that's on the breast distorts the breast. The incision itself contracts even without the radiation therapy. So it tends, when we make those lateral incisions, and you saw in the last one, it pulls the nipple laterally. And then the final thing is that it's also the best perfusion. So, and this is sort of that lucky thing as well. So that we're able to do something that looks the best, that also gives us the best chance to be allowed to do this because this is the best blood flow to the patient. So here are a couple examples, and one small advantage, and patients actually love this, but I used to tell them, we have to, your breast is going to be smaller, we're going to have to make the other, if you're only doing one side, the other side smaller, something to that effect. Now I actually tell them I generally have to make it a little bit bigger. I have to fill that pocket. The alloderm I'm putting in, that internal bra, if you will, has to be in contact with the skin. This is really a skin graft, so we don't want movement. And so this is a pretty standard result. And I think, thinking back to what I just showed you, this is worlds better. Here's another patient. It's pretty hard to tell which is pre-op and post-op. Pre-op is there as you look at the screen, this is pre-op, and this is the patient after a mastectomy and an implant reconstruction. Again, this was Dr. Valente and my patient. Timing-wise, what we're thinking about as we're doing it is really at this point, if that was direct to implant, those last two patients you saw, meaning the breast was removed and I didn't put a tissue expander. So they had the final operation. Generally, we can do some touch-ups on patients, but about half don't do anything. But direct to implant, so we go right to radiation therapy, no delays. Since we have gotten better at it, we can count on viable tissue that's not going to die and delay any of these treatments, such as chemo and radiation. Also, when we do a tissue expander, what we'll often do is tissue expander, then radiation therapy, and exchange 6 months to a year later. But you can also do the TE, and within a month, put that final implant. In other words, get everything to heal properly, put the final implant in, and you're still not delaying radiation therapy. So that's also kind of a newer way to do it. Or if patients really want autologous, put that tissue expander in. This is the old way of doing it as a placeholder. So, to really get this stuff covered by insurance, to really incorporate this in all of our plans, we have to prove superiority. It's pretty hard to do that. And if you look, there really aren't a ton of papers. I kind of showed you the papers that are out there. A few of them are our papers. Otherwise, there'd sort of be nothing. But the reason it's not an easy task is because every patient is a different size. Every breast is a different size. Patients have different expectations. And then when you get down to it, how do you say one is better than the other? I'm going to show you some examples of this. The type of reconstruction is often dictated by both the patient's health and by what they need as their further treatments. And sort of judging aesthetics, the patients can have a warped sense of what is a nice reconstruction because they're happier about the tummy tuck they got out of their DEEP than they are necessarily the breast reconstruction. There was a series of Funky Winkerbean. I don't know if anyone has ever seen these, but all breast surgeons should see these little comics. They're actually quite good, and I use these in a lot. But here's what's going on. You see the doctor, you see me there on the left, balding with my glasses on, and explaining this to the patient and her husband, and he's saying, we have to go to this, small-breasted, we have to go to the smaller implant, and then bubbles going up from her head. It's just one humiliation after another. That's what the patient's sitting there thinking as they're going through it, or they're thinking about what they got told for chemotherapy. These are complex decisions, and I really want the patient to be a part of that decision. It's not easy for all these reasons. And adding to that, look at these two patients. This was one of the studies early on to look at patient satisfaction with their reconstruction. And here really is the dilemma. The patient in A was a self-evaluation as an excellent reconstruction. So I don't think there's anybody in the room that would look at that, particularly with what you just saw me show, and call that an excellent. I would judge that really extremely poor. And then you look at the other patient, and I'm going to show you one just like this that I did. This isn't my paper. She judged this a really poor reconstruction here on the right. So go figure. And this is not at all, it looks like you go, well, that's got to be uncommon. It's surprisingly common. But there are ways for us to deal with it. But even when you look at it like the third person, like I said, I would say the one was poor, et cetera. Even the third-party people. We try and incorporate medical students, lay people, et cetera, to look at pictures so we have and we do have a validated scale. But it's hard to come up with a number, and you can see these numbers are kind of hard to read. But the bottom line is there's a lot of discrepancy between what the patient says and between what the third-party evaluators say. So it's hard to come up with these numbers precisely. So, it's 2023, we've got ChatGPT. AI has to come into it. Maybe that get better. This paper really didn't, I think anyone would say if you look at that little tiny picture, this is not a great reconstruction. So the fact that ChatGPT could say that's not a good reconstruction is not a real advance. But I think as it gets better, this will go somewhere. Here are ratings done for our papers, and there was consensus on what's a 3, what's a 4, and what's a 5. So I'll leave that up for just a second. How am I doing time-wise? Not too bad. So what are the remaining challenges? We haven't solved everything. Here's one of the things we haven't solved. If the slide changed, there we go. Patients that tolerate radiation therapy poorly. And you don't know that. This is genetic as well. So some patients go through radiation therapy, just like some people get sunburns, some people don't. They go through radiation therapy and you can't even tell they had it. Other patients go through it and you get something like this patient. And you can't do anything with that from a reconstructive standpoint except add autologous tissue. So that's kind of where it is. That still exists today. We still have to deal with that. Way we deal with it is with autologous tissue, not so much implants. Implants still don't work great in that scenario, although people have written about it. Trust me, they don't look good. Lymphedema. So this is a result of us doing our lymph node dissections and then the patient getting radiation therapy. Both of those are additive. And we haven't completely solved that, but we have made progress. So it is a devastating complication, and it affects up to 15% of patients who have that axillary node dissection and radiation therapy. So what we do, and you can see this paper with Dr. Al-Healy, Dr. Schwarz, myself, Johan, a whole bunch of us, and Dr. Valente. So this is reverse axillary mapping. So the breast surgeon comes in, injects a dye in the upper arm so we can tell which lymphatics drain the arm and which lymphatics drain the breast. And then by doing that, we can at least try to hook up these lymphatics again. It makes sense, and it does work. Papers are a little bit mixed on it. Our papers show it works, probably because we're better. No, I'm kidding. So here, this is just kind of showing it. So this is how we do it. These vessels are quite small. So these vessels are approximately 0.2 to 0.3 millimeters in size. So, you guys can think of what a millimeter is. It's kind of nothing. This is working at a level that we've never really worked prior to about 5 years ago. And then you see, well, did it work? Yeah, it works. So here's the lymphatic coming in. This is end-to-end. This is not actually the most common way we do it. We usually put multiple of these little teeny things into one vein. And it really is up to Dr. Valente and Dr. Healy, et cetera, to save us a good vein and to save us good lymphatics, or we can't do it. We use something called 11-0 suture. You can't even see that suture without the microscope. But you can see, here's the ICG we put in. It's going across there. That's a successful bypass. So now the lymph is draining from the arm. We've been able to decrease our rate of significant lymphedema from 15% down to 3%. Quite significant for something that really adds essentially zero morbidity, adds about an hour to the case. If it's sort of secondary, this is one of my partners believes this is really the better way to do it. I don't do it, so I don't believe in it. No, I'm kidding. He does this as it probably is a little beyond my aged capabilities, but he will take those vessels that are very even tinier than what I was just talking about, all the way down to 0.2, and directly hook them up in the arm to veins. He'll do extensive liposuction, both of those things added together, treat this secondary. So that first patient I showed you with significant lymphedema. I thought I had a slide showing that, but, well, this slide lower, this shows you what he was, this is his patient, this is Dr. Chen, what he was able to do with that lymphatic bypass. And they do get intense physical therapy as well, so pretty remarkable. So this was routine back in 2010 when I started this talk, at the beginning of this talk, and this is one of the patients I said to say, we can still do it, but, et cetera, et cetera. So this was really considered a fantastic result back then. This was probably as good as I could possibly do. And really, for the most part, if we knew you were getting radiation therapy, it was like a sword fight with the radiation therapist. It was sort of a hard no, and we would put it off. That has changed completely. And so this is where this is the interesting patient I was going to tell you about. So here's a patient that, again, this is Dr. Valente and I. You're getting the theme that the two of us work together. So we pair up. This patient had a bilateral mastectomy, immediate reconstruction with implant. Guess which breast she likes better? She likes the irradiated side. This is our new problem. This is our dilemma 2023. So now, with an implant, we can get a superb result. Arguably, it's made better by radiation therapy. This is what the patient prefers. So now you've got this. It's very hard for me to match this. You know, you would think with all those things I did, I have to put a lot of scars on the breast. And this patient actually went away from me mad. She found another plastic surgeon. He did something. It didn't work great. It's very hard to do. So this is not even a criticism against him. Because that breast now has this implant in it, there's not a lot of tissue that I can rearrange to make this better. So there are some things we can do, but this is dilemma 2023, and these are the patients we have that are unhappy now, which, you know, I think everyone would have been thrilled with 10 years ago. Here's another example of a patient that Dr. Valente and I did. This is not nipple sparing, but radiation on the left, and the patient actually, again, prefers that irradiated side. So very interesting. These are prepectoral. I'm going to say a little bit about that in a second as well. So what are the other dilemmas for 2023? One of the reasons that patients aren't, some of these patients that have really great results aren't as satisfied is right here, social media. This is a patient, you know, saying the swim flap. I don't know what the swim flap is, but, you know, Goldilocks is a very popular thing on social media. What Goldilocks is, you know, someone sucks fat out of the legs and belly and injects it in the breast, which sounds insane. Wait till I show you some pictures. It does work, but social media has really increased what patients expect. Remember that near perfect result I showed you? That's what every patient comes in expecting. So now it's rare to get those patients that have what I thought were terrible results thinking it's good. This is something called this may be, I think this is the swim flap. And this is, you see, accepted because this paper hasn't been published yet. But this is not my patient either. But this is a patient who had a latissimus dorsi and then fat injection. And we use fat injection a lot. And it works in radiation therapy. Not as well, but it still works. And sometimes small improvements are big improvements for radiation therapy. This one's even more remarkable. This is not a radiation patient. But here's a patient who had a mastectomy. There is no implant here. There's no flap. There's nothing but fat grafting. So this is a patient that underwent 9 sessions of fat grafting, liposuction on the belly, liposuction on the legs. That's pretty remarkable. And that's a nipple reconstruct. That's not her nipple, obviously. And she had a reduction on the opposite side for matching purposes. So that's on the horizon. But basically, I'm not going to spend a lot of time on this slide. Bottom line is we no longer are jousting with our radiation therapist. Basically, we're agnostic, for lack of a better word, to whether patient's getting radiation therapy or not, and we go with whatever the appropriate reconstruction is. And for me, it's obviously, you can probably guess from this, that I've changed from doing mostly autologous to doing mostly implants. That's not true for all of my partners. So we don't fear it anymore. This is the last slide, but I thank everybody. But I want to take a minute to say why this really works. And I think the most important thing to take away of all these things is none of this that I showed you would have happened without the collaboration, which this summit is always about. And so it was, you know, Dr. Shaw can agree, there was a time when they would sit there and say, you have to put it under the muscle because that's the only way we can adequately treat the. Well, through collaboration, we discussed it with our radiation oncologists, and we all came to an agreement that we can do this, we can get these superior results by making changes. And then from the standpoint of the surgeon, the breast surgeon and plastic surgeon, we have huge egos. I don't think anyone would argue that. So it's pretty hard to get us to change our mind. And you really had to, 20 years ago, I had to walk on eggshells to make suggestions. But Dr. Valente and I know this works for the others in this group as well, at the beginning of every case, we will discuss every operation, how we're doing it, what the best approach is, the breast incision, et cetera. And then the other thing is that she'll sit there and tell me, well, hey, so-and-so did it this way before, what do you think of this? And so the two of us, and I'll also say, make a suggestion, well, is it possible for you to do this? And we change on the fly, and we keep getting better and better and better every week we do this. So it's a collaborative effort. So thank you.